the best palliation is an effective
Right.
treatment,
Right.
no question.
Right.
It's interesting you bring that up because traditionally that patient would not be considered for TDXD, but you have to weigh risk benefits. So then working with a cardio-oncologist like you did, I think got that patient access to a drug and is feeling better.
So a lot of what we've talked about is very inside baseball, right? We know the language we use, progression-free survival, overall survival, and sometimes when I'm speaking with my patients, I realize I just see they glaze over, and then I think about how do I frame this conversation in a way that they understand, that is meaningful, and that they can participate in. So how do you present the data you presented to the patient so that you can have that conversation and make that joint decision?
Absolutely. You have to present the data in a language that the patient understands. I'm very traditional. I usually have a sheet of paper and a pen, and I first start with a diagram in terms of what an ADC is. If I'm going to talk about TDXD, draw the diagram, explain how an antibody drug conjugate works and why potentially it could control the disease or control breast cancer. Then I start talking about, what our goal of therapy is to prolong survival and to improve your quality of life. And with survival, we've seen TDXD outperform standard of care. Then I talk about quality of life. And what we've seen with TDXD, I talk about potential side effects in terms of nausea, in terms of monitoring counts, the hair loss, and then the rare but serious toxicity of pneumonitis. So I tell them that we'll monitor you very closely. If you have any shortness of breath, any cough, let us know, because that could be a sign of lung damage from this drug. And then at the end, again, I emphasize, we will be with you. Just because we're prescribing the drug doesn't mean it'll stop. We will be monitoring things closely, and we might need to adjust. At any given point of time, we make the best decision.